Hi, I'm John Hartung, and I hope you are wondering who this woman is. And I want to tell you. But first, let me explain why I want to talk to you about reading and doing medical research. It's because Dr. Cottrell and I have been the editors of this medical journal for the past 24 years. So I have gained an insider's view into how research papers get processed, and it's not always a pretty picture. Despite the peer review process, the fact that every paper is sent to experts for their opinions, what gets published in medical journals is very much a reader beware proposition. So I want to give you some tips on how to be critical readers. And with help from Augustina Otero, I hope to give you a standard that you can use when you do research yourself. All of that will take about 45 minutes, but there's a point about halfway through where it would be a good time to take a break. And I will let you know when we get there. Let's start by looking at some published opinions about the condition of the medical literature. Every 4 years for the past 25 years, JAMA has sponsored a major international congress that examines the empirical integrity of articles published in medical journals. Let's read from the summary paragraph of a report on the 4th Congress. There seems to be no conclusion too unjustified, no design too warped, no analysis too self-serving for a paper to end up in print. Too harsh? It might seem that way, but this is a verbatim repeat of the conclusion drawn from the 3rd Congress. How could this be? A report on the 5th Congress addresses that question. The peer review process is biased, patchy at detecting important methodological defects, and almost useless at detecting fraud or misconduct. Indeed, between defects in papers that peers review and inadequacies in the peer review process, the condition of our literature is discouraging, if not alarming. And bias seems to be the most corrupting force. How powerful can bias be? Since 1964, we have known that if investigators believe that they are working with a strain of highly intelligent rats, those rats will actually perform better on rat IQ tests, even though they are just ordinary rats. Experimenters believing their subjects to be maze bright obtained significantly better performance from their subjects than did experimenters believing their subjects to be maze dull. Both groups of investigators examined the same rats. If investigator bias can affect the behavior of rats, what can it do to people? This investigation tested 2 experimental treatments against a placebo control, and all patients were examined by both blinded and unblinded neurologists at each assessment. Neither active treatment regimens were superior to placebo, using the blinded evaluating neurologists' assessments of disease course. But the unblinded neurologists' scores demonstrated an apparent treatment benefit at 6, 12, and 24 months. Bias is so powerful that when physicians believe that they are giving their patients an effective treatment, physician optimism can be perceived by patients and reduce their symptoms while they are being examined, just as physician pessimism can exacerbate symptoms in control group patients. So, in addition to misperceiving their patients' symptoms, the unblinded neurologists in this study probably affected their patients' symptoms. A paper by Altman and co-authors, probably the most respected analysis group in the world today, examined 146 meta-analyses of 1,346 clinical trials and found that when investigators were likely to have known which patients were in the placebo group and which in the experimental group, they exaggerated the benefits of experimental drugs on subjectively assessed outcomes, like Glasgow Outcomes Score and NIH Stroke Scale, as distinct from outcomes like death, which are difficult to misclassify. So bias is both powerful and pervasive, and the quality of evidence presented in high-status journals is no better than the evidence presented in less widely cited journals. This study assessed the empirical quality of 1,418 articles and found no correlation between the empirical quality and the impact factor, or citation rate, of the journals in which the papers were published. So, for example, comparing anesthesiology to anesthesia and analgesia, journals with very different impact factors across 2 6-month periods separated by a period of 2 years. The incidence of erroneous application of 394 inferential statistical tests was 78%. No differences were detected in the incidence of errors across time or across the 2 anesthesia journals. These kinds of results have been found in every field of medicine that has been examined, leading to conclusions like this. In modern research, false findings may be the majority, or even the vast majority, of published research claims. And you can't avoid false findings by limiting your reading to the better journals, because they're not better. They are not better because all journals publish papers that have been influenced by investigator and reviewer bias, the root cause of most empirical BS. As a journal editor and a researcher, I have had a front row seat to watch what happens when results do not support an hypothesis. They are frequently twisted and bent in the direction of the hypothesis, and if that twisting and bending is not sufficient, the hypothesis itself is twisted and bent toward the distorted results until there appears to be a connection. And all that is done by a committee, the authors, who decide how much twisting and bending they think they can get away with. But the result is always the same. And it often gets published. Where does all this garbage get started? In my experience, it starts at the beginning, at the planning stage, when people plan an experiment. As my department's resident statistician for the past 30 years, and after a decade as the chair of my institution's Animal Care and Use Committee, the committee that reviews proposals for animal experiments, I have read and heard hundreds of unintentional confessions of bias, and they tend to be expressed in the same way over and over. So many years ago, I decided to Record a few of those conversations. As we read through just one of them, see whether you can spot the key confession. Cocaine and aneurysms. Cocaine was at the height of its popularity when this exchange took place. Hi, Dr. Cottrell said I have to talk to you about my study. Okay, what's your study's question? Many of our aneurysm patients use crack cocaine. I want to show that crack increases the risk of aneurysm rupture. What do you want to compare to what? Nothing fancy. I just want to go through charts until I have enough patients to give a reliable estimate. An estimate of what? The percent of aneurysm patients who use crack. I think it might be as high as 20%. Of course, the big problem is the other things that crack users do, like smoke cigarettes, have a poor diet, live life in the fast lane. How can we control for that? Wait a minute. Suppose you find that the incidence of crack use is 20% and there are no confounding variables. Well, that would be great, but you know that there are confounding variables. Right, but forget the confounds for a second. You need to find the prevalence of cocaine use in the population served by this hospital. The police precinct has records on why. Well, suppose 20% of adults in this area use cocaine, but only 10% of aneurysm patients use cocaine. You would have evidence that cocaine protects against aneurysm rupture, just like smoking protects against Parkinson's. No, you don't understand. What don't I understand? I'm only going to be a resident here for 2 more years. Expletive deleted. I just want to prove that cocaine makes aneurysms pop. Believe me, cocaine is not good for you. This is one of hundreds of sessions in which I have heard the same basic confession. A confession that usually comes right up front. Do you see it here? It's right here. I want to show. And it's here. I just want to prove. When I ask, what's your study's question? I'm trying to find out what question is driving the proposed investigation. But I have found that most research is not driven by a question. It's driven by an answer. An answer that investigators believe with religious conviction. And the only question they really have for me is, how can I show the world that my answer is true? So how can you tell whether a study was driven by an answer, by somebody's bright idea, by a belief about the truth, or driven by a question? A question that drove investigators because they wanted to find the truth. There are many ways to tell, but one of the best ways is simply careful reading, because with astonishing frequency, authors tell you. Here's an example that is currently online. You can look it up this afternoon. It tells the world about a large, ongoing, government-sponsored investigation, the FAST MAG trial. I have enlarged this key sentence. The purpose of this multi-center randomized double-blind phase 3 trial is to demonstrate that paramedic initiation of the neuroprotective agent magnesium sulfate in the field is an effective and safe treatment for acute stroke. Notice that the purpose is not to find out whether magnesium is effective in this setting. The purpose is to demonstrate what the investigators believed to be true before the first patient was enrolled. This is where they tell you that the research is driven by an answer. Let's look at a typical example from the peer-reviewed literature. protected carotid artery stenting versus endarterectomy in high-risk patients. And like most people do, we'll cut straight to the conclusion. Among patients with severe carotid artery stenosis and coexisting conditions, carotid stenting with the use of an emboli protection device is not inferior to carotid endarterectomy. So a less invasive procedure, stenting, is not inferior to a more invasive procedure, endarterectomy. Now let's go to the part of papers that nobody reads, the statistical analysis section. The randomized trial was designed to show that carotid stenting was not inferior to carotid endarterectomy. This is where they tell you. In my experience, people who talk that way and are so oblivious that they even write that way do research that way. In fact, having read this paper and having noticed how sensitive the analysis was to the selection of coexisting conditions that were used to adjust the analysis, I suspect that this study was actually designed to show that stenting is superior to endarterectomy. But the data could not be tortured into complete submission. So the authors twisted and bent their hypothesis toward the tortured results until there appeared to be a connection. Either way, whether the original hypothesis was superiority or non-inferiority, real research is designed to find the true answer. It is never designed to show that a particular answer is true. And as often happens when research is driven by an answer, a better, larger study finds a very different answer. This is the same question tested in the same category of patients. Based on a power analysis, the study was designed to have 827 patients. But the trial was stopped prematurely after inclusion of 527 patients for reasons of both safety and futility. At 6 months, the incidence of stroke or death was 6.1% after endarterectomy and 11.7% after stenting. Twice as many deaths with stenting, in an investigation that was inspired by an investigation that was driven by an answer. And someday stenting may displace endarterectomy, even in high-risk patients. But an MRI investigation published in 2010 found 3 times more new ischemic lesions with stenting. So, we're not there yet. We're not very close. And we may not get there. This would be a good time to take the break that I mentioned. Before we investigate how this kind of thing happens, how hopeful treatments gain more acceptance than they should, by looking closely, very closely, at an issue that took 11 years to come full circle. Hypothermia after head injury. The story started with this paper from the University of Pittsburgh, which concluded that hypothermia hastened neurologic recovery and may have improved outcome. So the patients treated with hypothermia got better faster, but they may or may not have had improved outcome. May is an unusual word to use in this context, but that may be explained by analysis problems that Dr. Cottrell and I detailed in an editorial published shortly after publication of the Pittsburgh study. The short story is that the Pittsburgh group increased the risk of getting a false positive result by testing their hypothesis 6 times. Twice at 3 months, twice at 6 months, and twice at 12 months after injury. Each time on all of the patients included in the study and separately on a subgroup of those patients. All that to get just one result, only on the subgroup of patients, 12 months after injury, that had a p equal 0.05 probability of being a false positive, just by chance, with all of the prior results being not statistically significant. This is like when my daughter used to show me magic tricks. If she screwed up the trick, she would just say, "Wait, that one didn't count, let's start over." And I would say, "Okay." And if she screwed it up again, she would say it again. And this could go on for quite a while. But eventually she would get it and say, "See, I really can do magic." Unfortunately, this has too much in common with my daughter's magic tricks, because there are far too many P's in this analysis pod. And to hold the cumulative risk of getting a false positive result just by chance below 0.05 after 3 post hoc analyses on a full group and a subgroup of patients, the final analysis must be significant at p less than 0.05 divided by 6, or 0.0084. Which means that the result that drove this conclusion had way too high a probability of having occurred by chance to be statistically significant. And I suspect that this word "may" was chosen to deal with that criticism from one of this paper's reviewers. I think the author's original conclusion was simply that hypothermia improved outcome. And my suspicion was strengthened when I read a review article written by the Pittsburgh paper's principal investigator and published 2 months later. In that article, which reviewed prior papers on hypothermia after head injury, none of which were statistically significant, including his own papers reporting his results at 3 and 6 months after injury, he wrote, in the largest of these studies, that is, his report on his patients 12 months after injury, the Pittsburgh study, therapeutic moderate hypothermia was shown to cause a significant improvement in the neurological outcomes 3, 6, and 12 months after injury. So, we went quickly from moderate hypothermia may have improved outcome in one journal to therapeutic moderate hypothermia was shown to cause a significant improvement in outcomes in another journal, with both conclusions based on the same results. This is the answer that drove the Pittsburgh investigation from the beginning, and many colleagues bought that answer. In fact, according to the Pittsburgh paper's lead author, 34% of American neurosurgeons bought his answer within a year of its publication, including this group of investigators in Canada, who performed their study because a trial reported in the New England Journal found that hypothermia decreased the risk of a poor outcome. That study, the Pittsburgh study, was in adults only. These data provided a rationale for a trial of hypothermia in children, and we began our study shortly after publication of these findings. However, while we were conducting this trial, a large study of hypothermia did not show meaningful benefits in rate of survival or in functional outcomes, and documented more complications in adults who were treated with hypothermia. The study they refer to, the study that did not show meaningful outcomes. The Clifton study was designed to include 500 patients, but it was stopped by its Patient Safety Monitoring Board when it became clear that hypothermia was having no beneficial effect and was causing statistically significant adverse side effects. And by way of explaining the discrepancy between this result and the result of the Pittsburgh study, the authors of this much larger investigation wrote that the patients with hypothermia on admission, that is, patients who were already cold when they arrived at the hospital, but who were assigned to the normothermia group, were actively rewarmed in the Pittsburgh study, a practice that was known to be a bad idea. And that methodological defect was communicated privately. But in this larger study, the Clifton study, the body temperature of these patients rose spontaneously. They let patients who came in cold but were randomized to normothermia warm at their own rate. Therefore, the discrepancies in results could be explained by worsened neurologic outcomes due to rapid rewarming of patients in the normothermia group in the Pittsburgh study. So, statistical significance aside, hypothermia was not protective in the Pittsburgh study. The study's methodology simply damaged many of the patients in the normothermia group, and the difference between groups caused by that damage was presented as a benefit of hypothermia, which proves that when research is driven by an answer, there seems to be no design too warped for a paper to end up in print. And although the peer review process is patchy at detecting important methodological defects, there was no possibility of detecting this defect because the Pittsburgh paper made a very different claim. The patients in the normothermia group who had rectal temperatures below 37 at admission were passively rewarmed. And both this original published claim of passive warming and the subsequent personal communication claiming active warming came from the same source, the lead author of the Pittsburgh paper. So what actually happened to patients in the Pittsburgh study? I emailed most of the clinicians who managed patients' temperatures in that study, and all but one of them confirmed that spontaneously hypothermic patients randomized to normothermia were actively warmed. The one exception was an ICU doc who recalled using what he called warm air blanket overlays, better known as bear hugger blankets. But he asserted that this did not constitute active warming because they did not simultaneously infuse warmed fluids intravenously. When I replied, I would consider warm air blanket overlays to be active warming. No? He sent a one-word response. Yes. This is how it happens. This is the mechanism of bias. When we want something to be true badly enough, we deceive ourselves. This guy did. I have. And I would guess that you have. Because self-deceit is as distinctively human as language. Because we can talk ourselves into almost anything. And if a group of us wants the same thing to be true, the power of self-deceit becomes fantastic. We deceive ourselves until we are faced with the fact that we have deceived ourselves, something that is very hard to face. So, in addition to erroneous application of statistical tests, which were easy to detect, the authors of the Pittsburgh paper misperceived and so mischaracterized their own methodology. Because when research is driven by an answer, investigators will deceive themselves and so mislead the rest of us to protect and advance what they believe to be true and good, which is why the peer review process is almost useless at detecting fraud or misconduct. So what happened to those kids in Canada? Here's the full circle. There were 23 deaths in the hypothermia group as compared with 14 deaths in the normothermia group. Adjusted for clinical factors associated with outcome, in this case, primarily the fact that the kids randomly assigned to normothermia were more severely injured, so they were expected to do worse. The hazard ratio for death was 2.36, more than twice the risk of dying with hypothermia, so far more dead kids. Why? Because the Pittsburgh study, the study that inspired the Canadian investigation in children, was driven by an answer. A typical example of the underlying reason that there seems to be no conclusion too unjustified, no design too warped, no analysis too self-serving for a paper to end up in print. Now let's talk about how research should be done. Just as bias lies at the heart of bad research, so an unusual perspective lies at the heart of good research. And I gained some insight into that perspective from Augustina Otero, the world's greatest prostitute. Reckoned to be the greatest because she made about $20 million between 1885 and 1915, during an era when the United States paid $7.2 million for Alaska. This was an unimaginable amount of personal wealth, and she earned it by becoming a coveted status symbol among the world's very richest men. Kings and princes and robber barons and one czar would brag to each other about having spent time with Augustina Otero. Unfortunately, however, in 1898, these four men took Otero out for dinner and then, for the first time in her life, to a gambling casino to celebrate her 30th birthday. And Prince Albert of Monaco, who owned the casino, made sure that Otero won, and won big, for her birthday. And she became addicted to gambling. And for many years thereafter she spent most of her nights in casinos, until she lost the last of her fortune in 1926, at which point she would have been destitute Had it not been for an American industrialist who left Otero the use of an apartment in Paris with a weekly stipend for the rest of her life. He arranged to have that payment made weekly instead of monthly or yearly, so that Otero would not face more than a few days without food if she gambled away all of her money. He knew her well, and like most of her patrons, he loved her dearly. And she really got her money's worth out of that guy's estate because she lived to be 97. But she spent the last 39 years of her life as a famous recluse. She refused to socialize, though she was in great demand, and she refused to give interviews, except one, to a newspaper reporter in the autumn of 1941. A brief exchange in that interview revealed a psychopathology that became famous in textbooks of psychiatry. The reporter asked, "What was the greatest thrill of your life?" Otero replied immediately, "To win at gambling." That's not what he was looking for. He was hoping for some salacious revelation about one of her famous clients. So he rather haplessly responded, "And second?" Again, Otero replied without a second of hesitation, "To lose at gambling." That became the diagnostic criterion for compulsive gambling. For a compulsive gambler, the most important thing in life is to be in the game. Even losing is a greater thrill than whatever is in third place. I submit to you that experimenter bias is normal. Bias is a default program of human nature, especially when finding an hypothesis to be true means finding a way to help people. But I also submit that real scientists cannot be normal people. Researchers need to have a psychopathology that I call compulsive empiricism. For a compulsive empiricist, finding an hypothesis to be false, showing that a drug or a procedure, like hypothermia, is not useful, must be exhilarating. It must be the second greatest thrill in life, because for a real scientist, the most important thing in life is to be in the game. The game to find the truth, not the game to find the cure. How can we change the culture of research so that objectivity is admired more than finding p to be less than 0.05? I suggest that before becoming involved in a research project, we give ourselves and our colleagues the Otero test. Ask what-if questions. Ask, what if we find data that contradict the hypothesis? What if we find blue instead of red? If the reaction to your conjectured result is that it will not happen, or that if it happened it would mean that there must be some hidden flaw in the methodology, or if the investigators are sophisticated enough to not reveal a bias, but their projected sample size is not big enough to provide enough statistical power for the result to support a negative conclusion, then the Otero test is negative, and you need to find a different research project. But if the reaction to your what-if questions is an almost perverse delight at the prospect of finding the hypothesis to be wrong, and the sample size is big enough to do that, then the Otero test is positive, and you need to find a different research project. But if the reaction to your what-if questions is an almost perverse delight at the prospect of finding the hypothesis to be wrong, and the sample size is big enough to do that, then the Otero test is positive, and you need to find a different research project. and you have found a good research project. A project that is driven by a question and not by an answer. But what about would-be scientists who refuse to take the Otero test, or who fail the test and do answer-driven research anyway? There is a way to deal with those people and clean up the medical literature. The way things work today, authors can have a paper rejected by one journal and then submit a doctored version of that paper to another journal, a practice that can be used to disguise a fatal flaw so that new editors and reviewers can't see it. My guess is that most answer-driven research would not be accepted for publication if all journals received submissions through a central clearinghouse. A clearinghouse that would track each manuscript's submission history and forward all prior versions and all reviews of all prior revisions with each submission of each manuscript, so that every editor and reviewer could see the burning questions that have not been answered, the problematic information that was thrown out, and results that have been changed. Software has already been developed to detect plagiarism. That software could be modified to include comparison of each manuscript that is purported to be the first submission of a new manuscript to all other papers that have been submitted through the clearinghouse, so that authors could not get away with the claim that a rejected manuscript is the first submission of a new manuscript. If editors and reviewers received every paper's complete history, they could distinguish between a manuscript that should be rejected for the same reason that it was rejected before, as distinct from a paper that should be considered because it was rejected by a higher status journal only because that journal's editor thought the paper would not attract enough attention to maintain that journal's high impact factor. If we had such a clearinghouse that would also require registration of clinical trials at clinicaltrials.gov, and for animal experiments require a copy of the protocol that was approved by the author's Institutional Animal Care and Use Committee, and require access to all raw data files, a requirement that I and Drs. Cottrell and Giffen recommended in 1983. If we had a clearinghouse that would put all of these very doable procedures in place, the medical literature could be converted from a place where clean information is so hard to find to a place where physicians could easily find information that would extend their capacity to help their patients with far less risk of being subjected to misinformation that could harm their patients. Thank you for listening.